This is the next major heading. We talked about experimental designs, and that's the only one that shows cause and effect. And now we want to focus on observational designs. That which is happening in nature that we observe. Now, as we noticed in with experimental studies, there was two types of them: community and clinical trials, and then we mentioned that there were three types of clinical trials. There are prevention trials, intervention trials, and therapeutic trials, and you need to know the difference of those. I mentioned the type of study that provides causation. That's an experiment, and an epidemiological, medically based experiment. That's what we still believe is causation. What studies provide evidence for association, correlation, connection? What would you say there? That's observational. Now, how many different types of observational studies are there? I know that, whoops, I got jumped ahead of myself. My apologies. How many different types are there? There are four, right? There are four of these observational studies, and we're going to cover them one by one. There's a cross-sectional study, a slice in time, or a prevalence study. And you know the difference between prevalence and incidence, and you know that prevalence is more comprehensive than incidence, and you know that prevalence alone is just a count, it's not a rate. We will cover a case control um, study, and we will talk about a relative odds, or commonly known in the research, the summary statistic is known as an odds ratio. And what we're comparing is disease and non disease participants selected in the present. Then we have a historical prospective, and this is the one people seem to have the most difficulty with, and I'm not quite sure why. We have an exposed and non-exposed participants selected in the present, where they were exposed to an ill or an untoward event in the past, and we'll go over that. A prospective longitudinal study is participants selected in the present and they're followed over time. This is the gold standard in observational studies. Okay, the gold standard overall is an experiment, and with the prospective longitudinal study, and I'll tell you there's some of the various names for each. We can calculate both incidence and prevalence rates, and we can do the counts. And we can calculate group and population statistics. And this sometimes confuses people too, but I will try to be diligent and systematic so you're not confused. That's my job. Okay. Um, as we go through, um, um, the next slide has to do with an observational study. Now, I've mentioned this definition many times, and this is a case where the experimenter manipulates nothing. They don't do anything. All the person does is observe what is already happening. Okay? That's what an observational study is. Snow observed what was already happening. And we come into situations periodically that's all we ever do is observe what is happening. Okay. Um, the last point has been the focus of psychology and education. And I want to show you this last point. And what we are looking at, synonymous with a non-experimental, a word synonymous with non-experimental or quasi-experimental study designs is Snow's observational study. Okay, but that's what I'm doing here when I use non-experimental or quasi-experimental. I'm describing an observational study in social psychological research design method terminology that came from Campbell and Stanley in 1963. We are operating, however, from a public health, epidemiological, medical perspective and not a social science one. Okay? Now, let's go back to the second point. Any change or difference in one characteristic are studied. Any change in how many characteristics, one characteristic, are studied in relationship to changes or differences in another without any intervention by the investigator. Again, the experimenter manipulates zero. Okay? This is something that's going on in nature that the investigator comes across. Okay, there are 4 types, and I want to go over the 4 types. A cross-sectional, slice and time, and I'll show you that. And we looked at cross-sectional studies when we did the prevalence exercises that I went through with you very carefully at the beginning of this course. We have a case control study, and it's often seen just like that and written out, and sometimes you find it in the study, in the title of the study is case control. Then the next one is a historical prospective study. This is the one that I think causes people confusion, and I hope by the time I'm done that you will be very clear about it. And then we have a prospective or a longitudinal study where we follow people over time. And I might take a group of your classmates and I might start and measure certain characteristics, and this is just one type of study design, so don't get locked in on this, and of a prospective longitudinal study, and I might follow them over time, and they would self-select into ill versus not ill. And this is the closest to a causation study, but remember, causation is determined by experiments. These are all associational studies. Every one of them I have listed here is an associational study. It's a connection between 2 variables. It's a correlation between 2 variables, however you want to say it. A does not cause B. Okay? And I'm reviewing a lengthy manuscript right now where this term is being used incorrectly. And I see terms used incorrectly all the time, and I don't want you to be guilty of it. And one of the terms, another term I hear used incorrectly has to do with cohort. And cohort is reserved to mean a group of subjects followed over a period of time. The term applies only to prospective, longitudinal, and possibly historical prospective studies, depending on whether people are followed forward in time from the present and beyond. And you'll begin to see this and understand it as I break down how the study designs are laid out. Okay, but you be careful with the use of cohort. They'll say, I'm studying a cohort, And I said, oh, are you doing a longitudinal study? No, I'm doing a cross-sectional study. Well, then you aren't studying a cohort. Well, I'm doing a case control. No, I always tell them, no, you're not. You're not studying a cohort. That term is exclusively reserved for a prospective longitudinal study. Okay, this is a diagram that I think you'll find very helpful. As I go down here, you'll see the word cross-sectional. This is a cross-sectional study. This is a present, and we're going to measure behaviors at a given point in time. Now let me be more specific about what that means. That could mean July 1st, August 15th, December 13th, January 6th. It's a specific point in time. It's one day normally, 1 24-hour period. It's a slice in time. That's a word that is a synonym for a cross-sectional study. So you can see it's taking a cross-section at the present. I'm going to gather a group of people. I'm going to put them in a classroom, and I'm going to give them this questionnaire or survey. Now, it doesn't always have to be a questionnaire or survey, so don't let that fool you. Now, with a cross-sectional study, how you determine it is when it's given. So it's given on a single day. Now, don't let this confuse you, but you can look backward in time. You can ask people through a question to look back in time. How many caries, dental caries, did you have 2 years ago? You can look forward in time, and you can ask questions pertaining to an out-date period. Okay? So it should be noted that you can, with a cross-sectional study, have people look backward in time and forward in time, but the criticality is the date in which it's administered, and it's usually administered on one day. Now, a case control study. We select cases and controls in the present. Okay? Now, I want to make a point here. It should be noted that it's not time that distinguishes a case control study from a historical prospective study. It's not time. It's not time that makes that distinction. What distinguishes the two types of studies is that case control studies begin with diseased, and you can write in diseased, and non-diseased subjects right here are participants. Select cases and controls. You select those with the disease, and you select those without the disease. Whereas with a historical prospective study, the study begins with exposed. People have been exposed to a disastrous event in the past, and those who have not been exposed. Okay, so these are diseased, okay, and non-diseased, and this is exposure. Okay, so you got to remember that these two are exposure. This is diseased and non-diseased. A prospective study, this one, is where people are followed forward in time, and they may be followed for multiple years. We have all kinds of examples where we have prospective studies, and they're riddled with problems, but they answer questions that no other study design can answer. And remember, this is a gold standard. This is the best observational study that you can conduct. So we select a cohort, classify as to expose behavior. And there's a couple of design types, and I want to distinguish those for you when we come to a prospective study. And notice I'm using the word cohort. That means followed in time. Okay? So don't get confused, and you'll hear that term misused all the time. I smile every time, often when I go to a thesis or dissertation defense, because you can tell people aren't up on their epidemiology. They do not know it well, and it shows when they begin to throw terms like this around, as well as incidence and prevalence. And you just sort of, it's like running your fingernails across a chalkboard. It's just, or they'll talk about an outbreak or epidemic and pandemic, and they're using the words interchangeably, or they're using them wrong. It just tells you that they're not very sophisticated in epidemiology, and they should be, and you should be. This is part of your fundamental education. Okay, I want to talk about an observational study. Again, I want to make this point. Time is not what distinguishes a case control from a historical prospective study. What is it? What is it now? What distinguishes the two types? Okay, a case control study begins with diseased or cases, all right, and non-diseased or controls. A historical prospective study begins with what? They've been exposed to a disastrous event, and when we have unexposed people that weren't exposed to this disastrous event, for example, the 1918 influenza Holocaust that killed millions of people worldwide, so it was a pandemic, and we talked about that earlier on in the slides. But this you have to get and understand. If you don't understand this point, you're gonna have trouble on a test deciding whether it is a case control or a historical prospective study. Now, I want to talk to you about a cross-sectional study. We said a cross-sectional study was a slice in time. It's one date, one 24-hour period. Now, we can collect data in any variety of means that are more ethnographic means. Okay? By ethnographic, I mean interviews, random interviews, focus groups. So you can collect data that are different than binary data, 1 or a 0. Okay? Now, oftentimes when we do a cross-sectional study, we give a survey, a test, an instrument, a questionnaire. People are always asking me what are the differences between these. It depends. How's that for a political answer? Some of them imply that we have a psychometrically valid tool. That's another word for it. And that can mean test or instrument. Okay, and I recommend for you to get a hold of, and you can download it. It's called the Pink Book. That's all it's called. You don't have to look for any particular title, and you download this book. You can Google Pink Book. It'll come up, and it's free. And it's the official title is Making Health Promotion Programs Work, published in 2004, and it has conceptual models in it, and it has very specific information about how to collect qualitative data in a public health fashion. So it'll introduce you to intercept interviews. Let me give you an example of an intercept interview. Every fourth person that walks down the street, you interview. We had a syphilis elimination project in Marion County and in Indianapolis. And Marion County proper is Indianapolis. We have the State Department of Health, and then we have um, um, the other, the Marion County Health Department. Okay, and so we interviewed people, and so we did random interviews. We didn't. Random means we're not going to. We just every fourth one we just decided on a number because we decided how many we needed, and we had an idea about how many people traverse this particular sidewalk. We have key intercept interviews where we go to the people that may be gatekeepers or those in charge, and we interview them about a given topic. Okay, this is all cross-sectional. Um, so, and another synonym that goes with cross-sectional is point prevalence. So when you think of a cross-sectional study, you might as well write up here, right underneath here, it's a point prevalence study. Okay? And so it could be a prevalence study or a prevalence rate. And remember again that prevalence is more comprehensive than incidence. And I'll share with you how this study design can be used with a prospective study. Okay. I've already said that. You know that. Okay. Observations of a group are made during a cross-sectional slice in time. Okay, you're asking them to do something, you're either going to observe them or they're going to fill something out to inform you. Okay? There's no temporal sequence or cause and effect, it's an associational study. It's an association, a correlation, a connection, a relationship, whatever you want to say, between two variables. Now remember, when you correlate things, they don't have to make sense. If any of you ever meet me, you'll see that I don't have too much hair on the top of my head. Strikingly handsome, but still don't have too much hair on the top of my head. Now I'm joking about the strikingly handsome, so don't get lost in that comment. But what I'm trying to say, that you could say that if my hair lays down on a given day, that means fair weather. Or if it doesn't, if it's straight up, that means bad weather. Well, so that doesn't make sense, does it? I mean, yes, I know we have good hair days and bad hair days, but my point is you can correlate any two variables. It doesn't have anything to do with causation. So I want you to keep that in mind. So we're looking at a particular point in time, and that we can ask people to look forward and back. And here's another key point. It can be the first point of an observational study of a prospective study, and you can use that as the first data point. You can give the questionnaire at one point to check prevalence, and then you can give the questionnaire 4 months down the road, 5 months down the road, 5 years down the road, whenever. But this is a point that I would say that you ought to underscore and learn and be aware of. Okay? Next, here's a cross-sectional study, and I just took something that is not founded on the research, but I'm trying to be a little ridiculous, but I don't know whether this couldn't have some potential. Usually radiation has to be pretty strong to cause people problems. But let me just read to you. It says a group of women are interviewed at one point in time. Okay, we know that's a cross-sectional study. It's a slice of time to determine their use of video display terminals and whether they had a miscarriage. Okay, and all the symbols are down here, right? N equals the pool of subjects, how many subjects we had here, and then E equals exposed, C equals miscarriage, X equals not exposed, and no miscarriage. So you can see we had exposed and miscarriage, we had exposed and no miscarriage, we had not exposed and miscarriage, we had not exposed and no miscarriage. Now let me make a couple of comments about this. Epidemiology, a lot of professions have preferred statistics that they like to use. When I was in pharmacy many years ago, a couple of decades ago, they wanted to do everything in a t-test or analysis of variance. Epidemiology has always used a chi-squared model. And the reason I call it chi-squared, if you look at chi-squared, you'll get an x and a 2 over it, and that 2 means it's squared. Okay? Now, another thing I want you to notice about what I've said, all possible contingencies or combinations are contained within these 4 categories or 4 groups that I have designated. All 4 of them are there. You can't get any more out of it. Okay? Every combination is covered or taken into account. All right, so I hope that now I'm going to show you how we're going to put this in a table. Okay, we looked at miscarriage and no miscarriage. We looked at exposed and not exposed. And so every combination of type of person would be classified or taken care of in this particular configuration. So we have exposed and miscarriage. We have exposed and no miscarriage. We have not exposed and miscarriage, and we have not exposed and no miscarriage. So we've got them all, right? And these would be true positives, and these would be true negatives. And here we go. Okay? Now, what do we like about cross-sectional designs? They're inexpensive to conduct and carry out. Another point that I made before is they can be the first data point of a longitudinal or follow-up or prospective study. I've used 3 terms now to talk about a prospective study. All of them mean the same, called by different terminology, but nevertheless they mean the same. Those are all synonyms. So don't get confused as you read the literature, because that's something that you're going to have to do. It's going to be required of you as a professional, is to be able to consume this kind of information. And you have to know when somebody's telling you something that's factual versus not factual, or there's a bias problem, or they simply don't know their science. And there's a whole lot of people who do research who don't seemingly know their science. Okay? Now, cross-sectional limitations. There's no cause and effect. You can't get cause and effect out of it no matter what you do, and you can see there's an association. It's impossible to ensure that variables are equally distributed among the 4 groups, or the number of subjects or participants is equally distributed across the groups. Okay? Notice this. May have uneven sample sizes in one of the 4 cells, causing a loss of statistical power, which I have not talked a lot about, but you should be informing yourself about statistical power. Cohen, 1988, as a publication. It's a book that's probably the most comprehensive book used. It's published. JAMA recommends that you do power calculations according to it, etc. But if you do not have enough people in each cell, you can use a non-parametric or distribution-free statistic to manage this problem. For example, chi-squared. Notice how I spelled it in the Fisher exact test. Now, the Fisher exact test will allow you to have a zero, no observations in a cell. A chi-squared test will not do that. You have to meet certain specifications as to when you use that test. All right, hopefully you're still with me. Often either exposure or caseness or both depend on recall, which is fallible. So if I'm asking you to complete a survey or questionnaire, and I ask you when you had, let's say you're 60 years old, and I ask you when you had a particular disease, you might have trouble recalling when that occurred. Okay? I want to talk about the Niemann bias. There's all sorts of biases or errors. This means something that makes the results uninterpretable. You don't know what to make of them. You have one answer that's as good as another, and you can't separate which answer is true and which answer is not. So this says that the Niemann bias that early deaths and those in which evidence of exposure has disappeared are missed. So if you die early from the problem that you're investigating, you obviously can't be included in the sample. So that's going to deflate the association between the variables. So I use the example of asbestos. If we're looking at asbestos, and we know back in yesteryear that engines of trains were lined with asbestos. Well, if you were doing an asbestos study, if you had looked at all the you couldn't look at all the engineers that had died. So your study would be compromised by the fact that not all people were available, and you couldn't possibly test them all. So a Niemann bias means that the people are not included in the study because the most severe cases are missed because people are dead. So this is a case where, if you want to go back to my example, and you're looking at the exposure to a video display terminal, and this is really a valid study. I'm winking as I'm talking to you. That those people who had died from that, or their infant had died, you couldn't include them in the study, and your results would be compromised because it would not be a representative example of the effects of the video display terminal. Now, case control study. Okay, I'm switching study designs in case you're wondering. I'm peeling these like an onion, remember? So I'm not off track here. A case control study is also known as a retrospective study. The more popular term between retrospective means to look back in time, but it's a more confusing term, and the more popular term is case control, because you have people who are diseased and non-diseased, and you select those people in the present, and then you look back to see what they might have been exposed to. Okay, and I just said that in the second line. Inferences about exposure are derived from data related to characteristics, experiences, or events, all occurring when? In the past. In the past. Right there. Bottom line. In the past. And usually what we're doing is we're doing a medical chart review. I remember doing one of these at Kaiser Permanente Hospital in Hayward, California, and Kaiser Permanente Hospital is a health maintenance organization. It was one of the first in the country, still in existence today, and where you would, if you were a client in that hospital, you would pay $1 per treatment, and the business that you were employed by made a contract for medical services, and you paid little for your medical services. The problem was that the doctors were involved in profit sharing, so as a result of them profit sharing, you might not get the full array of tests that you needed for diagnostic purposes. Okay? Okay, now I got off there. Many of you already know that this is still an associational study. We haven't changed. Anything that is an observational study is an associational study. So far, there's only one type of experimental study that shows cause and effect, and that's an experiment. Okay. Now, here it is done in a diagram. Present, what we do, we select cases with the disease and totally without the disease. So we want healthy people and we want diseased people. In an epidemiology, what we usually do is we look for the most diseased. So let me give you an off-the-wall example and to make it as profound as I can. Let's say we have we have 3 packs a day smokers, so they're smoking 60 cigarettes a day. Those would be the cases. Those would be the diseased people. And then we have people who have never ever smoked anything in their life, and so we compare those two groups because we're trying to look at those that are diseased versus those that are possibly non-diseased. Both groups could be healthy. Now, we look back in the past and for some exposure. You could, and in this case, we could look back for any diseases that this group, the diseased had versus any group that the non-diseased had, and we can compare them in the present. Okay, so we get this information and we compare it here. We don't compare it in the present. It doesn't make any difference. And let's say hypothetically that those who smoke 3 packs a day have 6 times the diseases that those people who were non-diseased have had. Okay? That's a case control study. Okay? But real important here, and I don't want to bypass this point, is defining a case. What are the criteria that go into defining a case? We need to have specific criteria, a list that is published, and those people who have a case have these characteristics, and those people who are non-diseased have these kind of characteristics. Okay, and we have more arguments over that, and if you don't define it and you're trying to report your study results and nobody else defines it either, we don't know who we're studying. And as a result, science does not progress. Okay, Selection of cases. How do we do it? Cases come from records from public health clinics, physicians' offices, health maintenance organizations, hospitals, industry, and government sources. Cases should be representative of all persons with the disease. Careful selection is a big deal in a case control study. Cases should be representative of all persons with the disease, and they can come from multiple sources. That's the point I'm trying to make here, and I want you to see that and recognize it. Okay? Now, selection of controls. Well, these are just examples. They could come from the general population. You can put an ad in the paper. From hospitals, could be family, friends, relatives, doesn't make any difference. But there are three general sources for identifying controls in a case control study, and there are certain advantages and disadvantages for using any one of these three groups. Okay? Now, I'd like to show you another diagram, which I think is very important and may be helpful to you. And this is an explanation based on looking at past information. And we begin here, and let me just read this to you because I want you to study this and not get confused. We begin by locating cases, and you would tell me, yes, we do, and we have a definition. And we have a definition of controls, our criteria. Among the cases and controls, some individuals may have some clinical disease, although they are classified as having a disease or no disease, respectively. This would take into account true positives and false negatives, which is a bias or error, and the controls would include true negatives and false positives. The true positives would appear in the yellow, and in the false negatives in the blue. The true negatives be in the blue, and the false positives would be in the yellow. So let's go through this real quickly. We're talking about in the first one, this would be the true positives, and this would be the false negatives, right? They all tested positive, and there was some exposure in the past and not exposure. Now amongst the controls, what do we have? It says we have true negatives would appear here, and they would fill the largest portion of this particular figure. And then if we have true negatives, we also have false negatives. So diseased or cases contain both false negatives and true positives. Controls contain true negatives and false positives. There is always some form of measurement error and bias, and that's why you get a few cases that are not exposed and a few controls who are. Okay? And hopefully you understand that. This is nothing different than what I've said all along in the contingency tables. This just shows you in a graphic way pertaining to a case control how you can have what? We can have true positives, and what would this be? False positives, and this is true negatives and false negatives. Okay? Now, advantage of a case control study. And this is why they're done, and you frequently see them reported in the research literature. They often can be quickly conducted. They generally don't cost much in comparison to other study designs. You can have small numbers of subjects. You don't need millions of subjects in order to do this. You can do them with whatever number of studies that your power calculations show that you can detect a significant difference if one really exists or not. One thing nice about it, when you're dealing with records and things of that nature, you don't have any attrition or dropout problems because you're looking at records and not dealing with participants. You have minimal ethical standards. You can't be accused of doing something wrong because you're looking at records again. So, and this is this is now. Excuse me. The least expensive of all study designs is a cross-sectional study design, and this probably falls next. That might be debatable, but it's not nearly as expensive as, what do you think is the most expensive one? That's a prospective study design. Disadvantages: cannot determine causation. Ideally, one determinant causes disease X, and we talked about that. Only provides information about an association, a connection, a relationship, or a correlation. So I've used 4 different words to explain the same thing. And the next, cannot determine prevalence or incidence. Only a cross-sectional study can determine prevalence. And we'll talk about incidence here in a minute. It can be time-consuming. The study that I did at Kaiser Permanente Hospital in Hayward, California, we had cases, and for every case we had to look at 1,000 cases to see whether we could get a match for the cases. Now, that's a match case control study, and I'll cover that in a minute, and that's a little different than what I'm explaining to you here, but they are time consuming, and you have to be real clear about your definition about case, or what we call it, casedom, and to identify cases who match the controls on demographic or key variables so that you don't run into an error or a bias or a confounding variable that means that your results are untrustworthy. Okay. I'd like to describe for you a historical prospective study, and oftentimes what makes it confusing is the word prospective, because there, as you know, there is something as a prospective study, which I'll cover next, but this is a historical prospective study, and it's usually distinguished between itself and a case control study. So I want you to begin to think about that as we go along, and then next I'll cover the I'll cover the prospective study and talk about a couple of study designs. A historical prospective study, obviously an observational study, that's all we've been addressing here for several slides now, is also known as a cohort study, a historical cohort study, a non-concurrent prospective study, and other terms. And I was trying to tell you that oftentimes different labels are used because people want to earmark these particular study designs as their own when they've been in existence for a long time. Now, exposure, now we're making a contrast with a case control with a case control study. Exposure is determined in the present, okay, and not in the past as in a case control study. And I'll try and make this real clear for you so you get an idea of exactly what I mean. A cohort study conducted by reconstructing data about subjects at a given time or times in the past to evaluate exposure or levels of exposure to a negative health event or disaster. Now, that doesn't mean a lot to you, I know, but we're going to select people in the present, and then we're going to look back to see what they were exposed to, and then what is the current effect on the individual. Okay, if you keep that in mind, you got it. The method uses pre-existing records, okay, and other relevant sources to evaluate health status in the past or somebody's vicinity to the disease-causing agent or disaster and their current health status. For example, people exposed to the 1917 through 1919 influenza holocaust and their health status at present. And we know that many people that went through the Holocaust, that survived it, had shingles. So we look now at the present, we say, okay, who had exposure to the 1917 through 1919 influenza holocaust, okay? We identify those folks. Then we go back and look at their medical records to verify that they in fact had exposure, had influenza, and then we go to the present and to see what health factors or risk were discernible. Okay, so now if we look at just for your information, because I think this information is interesting, the total number of U.S. deaths from this Holocaust was 765,885. And for 1917, areas included 27 states and the District of Columbia. In 1980, 30 states in the District of Columbia. 1919, 33 states and the District of Columbia. Now, I want to give you another example that it's not very well known, but it's a fact. During the Cold War, and this is true, during the Cold War, the Russians wanted to see whether or not they could survive it. And so they dropped an atomic bomb on one of their own cities. And they wanted to look at survivability over several years and whether there was any abnormalities that occurred, any anomalies in health, and of course, as I mentioned about survivability, how many people lived through it. And so what they did is the present was who was involved, and then they went back to check medical records to verify that these individuals were involved in it, and then what were the health consequences in the present. Okay? And they found all kinds of things. They found that infertility, they found parts of the body parts were greatly affected by the nuclear waste. Water was contaminated, and there was a real reduction in the number of people who were alive, but they found that there was a certain portion of the population that could survive this particular trauma no matter what. So I just share that with you as a way to discern and distinguish between a case control study and a historical prospective study. Okay? Now, these studies are done less now because of the growing concern about protection of privacy. But they tell us a lot. For example, I think it's important to know that people in 1917 through 1919 had influenza, and a result of that influenza, they had shingles. So that was a connection that we had noted between influenza and shingles. Okay, that covers really what I want to say about historical prospective studies. And now I'd like to talk about the CADLAC, or the gold standard of all observational studies, which is a prospective longitudinal study. And you can use a prospective longitudinal study if you meet the following specifications. It says when you can associate the disease with a specific exposure based on prior studies. So really what they're referring to is that you might use a more inexpensive study to determine whether you ought to use this very costly study to investigate a problem. So what would be a less expensive study would be a cross-sectional study or a case control study. Okay? You hope that the time is short between exposure and disease. So if somebody's exposed, the ideal is that you would want them to become ill quickly. You don't want something like AIDS, which has, somebody may contract AIDS and it may be 10 years later before the disease is actually present. That takes a lot of time, money, and effort, because with a prospective study, you're going to be having individuals in repeatedly, and you're going to be assessing them probably on an annual basis. And you can think about this. You can begin to think about the problems already in doing a longitudinal study, because follow-up in terms of contact is difficult, because people move, people drop out, people get divorced and have other family problems that are more important. They have to fly to a given location, normally to be tested. They stay in a hotel. It's a very difficult and costly study to perform. So the next thing is you have to have substantial funds that are available. Now, we have several of these types of studies going on. One of them is the nurses study. One of them is the NHANES study. And we've had several others, and they provide all kinds of valuable information for us. They're just expensive. Now, it would probably not be wise, because of my present age, to begin begin a longitudinal study, because you need to be able to follow people over a prolonged period, because you want to see what diseases develop over time. Now, we did do the Mensa study at Stanford. That's another long-term one, and I don't know what the Mensa requirements are anymore. I thought it was an IQ of 160, but I've heard that 130 is sufficient, so I'm not certain. But you have to have an IQ of a certain number. we also have that as an example of a longitudinal study. Now, what's interesting about that, and I'm just going to show you this next one so you can, I've already talked about this, but we found out that there was no advantages to having a higher IQ other than being able to learn more quickly. They didn't have fewer social problems. They didn't have fewer anything. They had as many divorces. They had as many financial difficulties. So intelligence wasn't a benefit necessarily in wealth or anything else. I know that at Stanford they would exclude people from the program who had near perfect GRE scores because they had trouble with these individuals in terms of focusing their attention, because they were capable of doing so many different things that they couldn't make a choice as to the one they wanted to focus on. So it became something that was not particularly beneficial and an enhancement to their credit or credibility. Okay, so you want to start a longitudinal study if you have a long life expectancy. Now, I want to also make another point here, because I think it's important for you to know, is that what they do when they begin to think about these studies is they have to have somebody waiting in the wings. If the primary investigator dies or loses, or the principal investigator dies or loses interest in the study, they have to have somebody to hand it off to. And as I say, it's a real undertaking that requires a lot of record keeping, but it tells so much about people's health over time and over the years. Now, this study is a prospective study, suffers from the same problems as every one of these studies, in that they have multiple names. Prospective study could be called a cohort study, a longitudinal study, a concurrent study, a follow-up study, an incidence study, and I'll talk about that, and a prevalence study. Okay, now remember, the word cohort is reserved for longitudinal study. Although you saw the word cohort, you're going to say, well, look, I saw that you said with a historical prospective study. If you look at the third bullet, they called it a cohort study conducted by reconstructing data about subjects at a given time. Well, what they're really referring to in that instance is usually when you get to the present. If they want to make it a longitudinal study, then they follow those people from the present through the remainder of their life. So sometimes the word cohort is used with a historical prospective study, but by and large you can count on the fact that this term is reserved for a longitudinal study, and normally people who are well trained in epidemiology reserve this term exclusively for a longitudinal study. Now, let me say this again. This is the only time it's appropriate to use this word unless you have a historical prospective study and then you follow the individuals from the present forward in time. It has to do with following somebody forward in time. So that's what cohort means. I'm going to follow you from this point forward. And it could be on any dimension. I want to make that perfectly clear too. Now, if somebody asked you which two studies are prevalence studies, how are you going to answer that question? Well, we know that the first prevalence study that you became aware of all the observational studies, was a cross-sectional study. Now, this can be the first data point. This cross-sectional information that we're going to gather could be the first data point in a prospective study. So this could be the first thing you could do. So can you get prevalence from a prospective study? Yes. Now, what's really unusual is, because we're looking at the development of new diseases over time with a prospective study, is that you can also obtain incidence. So a prospective study, why it's a Cadillac, why it's the gold standard, is because you can obtain incidence and prevalence rates from this particular type of study. Okay, that's the key to it. That's what makes it exclusive. That's what makes it unusual. And the downside of it is it's so expensive, it takes so long, and you have dropout, you have ethical issues anytime you're dealing with human beings. There's complaints. It's hard to get people to show up for appointments. All kinds of difficulties that go along with it, but it provides rich data. And we've learned so much about people by N. Haynes and the nurses study, and prospective studies or longitudinal studies. Now I want to show you a couple of common designs. Okay, there are more, but I want to show you the most popular ones, and again remind you that a prospective study can be called by any of these names. If you're studying for a quiz or something of that nature, we will use prospective study. We're not trying to confuse you in terms of terminology. If you understand a prospective study, you understand all of these other terms anyway. Okay, now here's the prospective study, and it mentions that generally there are two types of prospective studies. The first, people initially identified with a known disease and a cohort of unknown diseases are followed forward in time. Okay, so let's just look at this together. Let's take an example. So I have a group of diabetics, and I have a group that does not have diabetes. Okay, what happens to the health of these individuals over time? What's also interesting with the people who are unknown in terms of their disease, doesn't appear that they have diabetes, is we're wanting to see what the prevalence or the incidence is, because we have a number of new cases, right? When does that occur in their lifetime? How many people, okay, suffer from the disease? What are the health consequences, etc.? Okay, the second one, this is a cohort where the disease status is initially unknown and followed over time. So we have two groups, and they may have some exposure or not, but they are reviewed over time, and they become exposed to something or not, and then they classify themselves into particular study groups, and I'll share that with you in a minute. So don't get confused, just stay with me. Again, I've already made this point, and this is something that you should commit to memory and be knowledgeable about. A prospective study permits the calculations of both incidence and prevalence rates, as well as relative risk based on incidence rates. And relative risk is the gold standard. I haven't talked to you about any of the statistics yet, but oftentimes people will mention to you about relative risk. Immediately, because we know statistics are associated with study design. When somebody says relative risk, that means a longitudinal or prospective study. If somebody means an odds ratio, that means cross-sectional, case control, or historical prospective study. Okay? So that tells, and sometimes I will see written in the literature, somebody has done a case control study and they report relative risk. Well, I know immediately that's wrong. And there are different ways to calculate relative risk and an odds ratio, and I will go into that. But it's just a signal that they're probably not very scientifically sophisticated, and that's just a real easy way to either ask for clarification or to reject the paper. And usually you find out if they don't know the difference, the quality of the science is usually not very sophisticated. So I want you to know that, again, that statistics go with study designs. Okay, and especially with observational study designs. And I will be spending time with this here in a few minutes and hopefully be clear and concise with you as to how we go through the various calculations. Okay. A prospective study design 1. Usually the investigator selects his or her study sample from a defined population which consists of subjects with and without the disease. Okay? And I want to show you this. And here is how that study design looks. Okay? And let me go over this with you. Okay, so we have a defined population. Exposure status is unknown. And we have a non-random selection. We select from prior knowledge and history and interviews to confirm whether they've been exposed to something or not exposed. Okay? Then what follows, this is time, of course, and we're following them over time. Then we look at the exposed and we see what happens to them. And we know that there'll be a certain portion of those that are, we look what happens to them in terms of their health and health status, health risk. We can look at all the wellness characteristics too, whether if you want to. You could look at physical activity, you can look at mental, emotional health, whatever, okay, spirituality, okay. Now, we know that always that there's a proportion of people who do not develop the disease even though they are exposed. Okay? Now, when we move over to the unexposed group, we're going to have a few of those who develop disease. And we're going to have many that don't develop the disease, and this is what we would expect. So what we do is we select exposed and unexposed groups, right? That's what it says. Determine a time to how many subjects develop the disease in each group and how many do not develop the disease, which provides incidence by subtracting T2 from T1. Okay, so we're looking, over time, how many develop the disease. Okay? And that's what we're trying to do, and we know that if you're exposed, you're going to develop the disease. If you're unexposed, you will develop the disease. Of course, a lot fewer people. And what's made designs like this sort of complicated is, in the beginning, we didn't know anything about secondary smoke. So we would take smokers and look at them, and we had all these people in the supposedly unexposed group, because they didn't smoke, becoming sick. Okay? So now we have tertiary smokers. And tertiary smokers are those who acquire lung cancer or heart disease. Now remember, with smoking, it's heart disease and then lung cancer are the leading causes of death in that order. And just by sitting in an environment where there's been a lot of smoking and the smoke has been absorbed into the walls and into the furniture, you can develop lung cancer or heart disease. So that was a confounding variable that caused problems, and but generally, I just want you to understand the design, and I want you to understand the difference between design 1 and design 2, okay? Because I'm going to show you another one, and these are the most popular ones, okay? Second design. As mentioned, let me just stay with this one for a few more minutes. It says, as mentioned on the last slide, this is now putting it out in prose, so you can, if I talk too quickly or whatnot, you can read this for yourself. As mentioned on the past slide, start with a study sample drawn from a defined population. Then it says exposure status is known based on prior knowledge, history, interviews to confirm. Observations, screening tests are ways to confirm what you have suspected. And you might, for example, look at a noisy environment if we're checking hearing acuity and what was the difference in those people who were exposed to the noise and those people who were not exposed to the noise. Okay, next, both the outcome variable, hearing acuity, and the risk factors, determinants, are collected at the same time at T1, and that equals prevalence rates. Now, the study sample is followed over time, and at T2, a repeat assessment is done on hearing status, and then we calculate incidence rates. Okay? So you need a minimum of 2 data collection points to compute incidence rates between the selected exposure and selected outcome variables. So that should give you a pretty good idea about how this study operates and how this is one application, and I use something a little different than the typical health problems that you run into, but you can begin to think about the application to any number of health outcomes that you're interested in, and how a longitudinal study might be utilized. Or when you go to the research literature and you want to know more about a problem, one of the things I would see is how many prospective studies had been done, and I would look at those immediately, because they're going to probably provide you with rich information about the problem. They're going to talk to you about longevity. They're going to talk to you about the incubation period. They're going to talk to you about duration. They're going to talk about all those things in the communicable disease manual. Okay. Hopefully you're on board with study design 1. Now, let's talk about study design 2. Okay? It says exposure is unknown. Currently, everybody is disease-free. And we might look at a country, a state, a county, or a city, an ethnic community, an occupational group, any selected respondent characteristics that is of interest to you. And what we're going to do is draw a sample at random. Now, it could be from the Purdue population, for example. And Cohen, and I make you aware of this because this is still the premier book in the area for estimating power statistics, to see whether we have a simple a sufficient sample size to detect a significant difference if one really exists. And people always ask me about a definition of power. And this is probably one of the cleanest, simplest definition of power statistics, or an estimation of sample size. Now, we can't be 100% certain that we have a sufficient number of participants, but generally what I find is Cohen's calculations are pretty accurate and give us an opportunity to really determine whether a significant difference truly exists. And it's not because we don't have enough people that we don't see the effect. Hopefully that makes sense. Now we do an initial assessment to determine that all are disease free, and over time these people are going to separate themselves into two groups. Okay, and you can see the time period we're representing that over here. So over time something's going to happen to them, and depending on the outcome variable of interest, they're going to either be exposed to something that you're studying, or they're not going to be exposed. Or you may have a wide variety of things that you're looking at, and normally that's the case, and you detect the exposures. It could be environmental, occupational, it could be genetic, any number of factors that you might be looking at in terms of these individuals. And after that, you see who develops the disease and who does not develop disease, and the unexposed is the same way. Okay, so you can see the differences between the two types, and I hopefully this is clear and you don't have a problem with it. Now let me present it in a more narrative form for you. And it says, with prospective study 2, you draw a random sample, for example, of college students. You can't test all of them, so but our sampling is what's most important. Remember, I think I mentioned that we only use 1,600 people for the Gallup poll, and we have an accuracy or plus or minus 3%. And the reason why that works so well is the sampling frame of who they're looking for. They pick people who represent, they pick a person that represents many other people just like them. So a fallacy in science is a bigger sample size is better, and that isn't necessarily the case, and it doesn't necessarily rule out bias or error. So anyway, we're going to take a certain percentage, or a certain number, so we would select every 8 student, for example. And we do the power calculations to know how many students we need to select. We would establish definite criteria in advance for what constitutes a case. For example, the flu and residence hall outbreak. We would go to the communicable disease manual. All those requirements for what constitutes having the flu are laid out there. Serology is mentioned. You know very quickly who's going to qualify and who's not going to qualify as having the flu versus somebody who has a hangover. Okay, because we don't want to include those people as having the flu because they're a totally different group, and we wouldn't want them intermixed, which means confounding, with our group that we've decided are our cases. And so we're going to confirm this through surveys, roommates, and if possible medical consults to make certain that all are either are disease-free or have the disease. So we're going to sort into exposed or unexposed. Could also institute random sampling at this point if we had too many, or use the matched pairs designed based on demographic factors to reduce or eliminate confounders. Now I'm using terms here that you have not been exposed to. You don't know about a matched pairs design. I understand that. Don't worry about it. You're going to get exposure to that very soon. You don't know about confounders, but I've given you an idea that that's variables that are intermixed that you can't separate, and you can't tell whether A causes B. And that's what we're always trying to do. But you'll learn more about that. And that's why you're taking this class. That's one of the reasons. Okay, let's proceed. And prospective study advantages, management confounding variables, random selection, or matched pairs study, and I'll show you that in a few minutes. Study is not limited by past constraints, allows directionality, but it's not a cause and effect study. It is not a cause and effect study. Okay? The only study that is a cause and effect study is an experiment. It does allow us to say that A comes before B, and that's the first step in determining causality. Then if we wanted to do a causality study, if we wanted to go back to do an experiment to say that A precedes B, we can do so. Now, sometimes what happens in science, because these are all associational studies, all of these observational studies are associational studies that show a connection, a relationship, or a correlation, so we don't know the direction of what influences what, and sometimes we think that A influences B and find out that the sequence is that B influences A, so it's just the opposite. This is why we do science. And as I mentioned, it helps assess causation, but it's still not a causation study, and that is only done through an experiment. And I mention that here, and I show it. And one thing about the study that is a real advantage is that there are you don't have to rely on recall, because you're going to be doing various assessments, maybe on an annual basis or every other year, and you're going to be collecting the information yourself. Oftentimes it's serological testing. Oftentimes other medical screening procedures are used, such as x-rays and whatnot, and that's why the study costs a lot. But you're really not asking people necessarily, although you can, about a past event. People's memories are foggy. The study sample is going to age. Recall is going to become more difficult for some people. They're going to suffer from some diseases like dementia and other factors. Okay? And what makes this an important and unique study is that both incidence and prevalence rates can be calculated. Now remember, prevalence rates are calculated by two different study designs. One of the outcomes is from a cross-sectional study, a slice in time, and the other is from a prospective study. And what makes this study really unique is that you calculate incidence rates. Okay, now let's talk about this, the disadvantages of a prospective study. Undoubtedly, they're expensive and time-consuming, but our government, upon occasion, thinks that prospective studies are warranted, and we will learn a lot about health issues, and I tend to agree, and I think they're a very valuable contribution to science, and they're the gold standard. Also mentioned that anytime you deal with people, you can have ethical problems that occur. You can have complaints that run the gamut. Um, uh, these complaints are personnel can call the internal review board that reviews every study and make complaints to them directly. They can be of a discriminatory nature. They can be related to misconduct about how they were treated, any number of issues. The other problem with them is attrition. People drop out. And some of them may die, get divorced, relocate, move to another state or country. You don't have the follow-up information. They don't provide it. And so you lose valuable information from that particular person, and you can't start somebody else because these are a group of people that all start at the same time. So what I'm saying, you can't replace them. And there's a lot more opportunity for bias or error, and we have random or systematic error. Random error is just what it means. If you had a migraine headache, that would be random error because it doesn't occur systematically. You can't predict it. Systematic error has to do with, for example, with the poor design of a questionnaire. That's systematic because it's going to occur every time you administer it. Or if you have a phlebotomist that's unskilled in the beginning and becomes more skilled later on, that's a systematic error. Okay, we will cover calculating risks next.